Becky Benson. She's the Medical Director of Pediatric Palliative Care Program, the Director of the Ethics Consult Service, Clinical Assistant Professor of Pediatrics, General Pediatric and Adolescent Medicine at the University of Iowa Stead Family Children's Hospital. And she is here to talk on perinatal and pediatric palliative care, supporting children and families facing serious illnesses. Please welcome Dr. Benson.
Thank you. I'm on. Yep. Okay, well, I just made one person happy and a bunch of people not happy, so that's a good way to start a talk, right? So it's a little confusing sometimes being the palliative care consultant and an ethics consultant. So just yesterday I showed up in our pediatric intensive care unit and I went to the bedside of a patient and said to the nurse, "I'm Becky Benson, I'm with Pediatric Palliative Care, you paged me about your patient," and she sort of stared at me like, "No, I didn't." It's like, and then the nurse next door to her said, "Are you also covering the 2922 ethics pager?" And I said, "Yes, I'm Becky Benson, I'm with the Ethics Consult Service, you paged me about your patient." I don't know who I am or what I'm doing sometimes, but they're both, I think, really good services to have available for our patients, especially in a place where we're oftentimes really pushing the limits of what can be done for patients, and that can get us into situations that are ethically challenging and that can be distressing to parents, the patients, and the care providers. So I'm going to describe how perinatal, so even before an infant is born, we can be involved in helping determine care plans when we know that that infant is going to be born with a serious illness. And pediatric palliative care teams help families of children with serious illness by alleviating suffering, supporting quality of life, improving communication, and supporting decision making. And the pictures that I have in this presentation are from families who allowed us to use their pictures because they wanted to have their child remembered and they wanted to give back to our team and to the medical system in general. So this is a family whose infant was born with a condition that was thought to have a very low likelihood of having a long-term survival. And one of their goals for her was to be able to spend some time together as a family. And so they requested that she receive respiratory support and resuscitation right at birth. So she is intubated in this picture so that they could spend some time together as a family, get some family photos, and then she was later compassionately extubated and they had more time together with her after the tapes and everything was off and they could see all of her face, and this way she got to meet her big sister. So those are the kind of things that we try to offer to families in terms of figuring out which goals are important to them. For another family, they might have said, our goal is that they experience no medical intervention and that, you know, all they feel is comfort and being held, and so they may have gone that direction with it. But what we want is to learn from them what's going to be meaningful to them and then help figure out how we can support that. So while we have many fewer deaths in children than there are in adults every year, it is a phenomenon that happens. And sometimes people ask, you know, how can you work in a field where you encounter pediatric death so frequently? And, you know, I think everybody has a niche that works for them. Like, I could not be a respiratory therapist because, as many of my patients know, I'm kind of grossed out by the sound of suctioning and secretions. Sometimes I actually have to, like, step aside and turn on the water so I have something else to listen to. My long-term patients really enjoy making fun of me about this because many of them have suction issues. So that would not be my niche, right? But I do fit into this niche of working with families when their child has a serious illness because I feel like there is great potential to be able to make it better for them than it would be otherwise. And so my goal is they're going through a situation that we usually can't stop, but we can certainly change how it goes for them and make the experience as meaningful as possible, feel like they had a voice, feel like they were the best parents they could be. And so that's what I think is important to me about working in this field. So I just have some stats up here, and what I really want to focus on is kind of this graph. So of children who die, about a third of them die from a life-limiting or life-threatening condition. And these include things like cancer, congenital heart disease, neurodegenerative or neuromuscular disorders, metabolic or genetic congenital disorders that survive infancy. So these are things that their families have time during the course of their illness, often to hope that there'll be a cure or that things will get better for their child, and then later to recognize that certain things in the body aren't working anymore and that they're going to have to start thinking about what's most important to them for quality of life while their child lives and for end-of-life care. So the life-limiting conditions there in the red, and then there's an other category that includes things like unintentional injury, so things like shaken baby or other forms of traumatic injury to children, homicide, SIDS, suicide is the blue category, and then at least a third and sometimes up to a half in some studies are birth-related conditions or deaths within the first year of life. And that can be anything from complications of premature birth to a injury at birth leading to hypoxic ischemic encephalopathy or congenital anomalies that aren't able to be consistent with living a long life. So those are the kind of patients that I'm typically seeing. Sometimes those who die even of an accident or trauma, they will make it to a care center and either be in the ER or the PICU, and so their families sometimes still have decisions to make or can benefit from support within our healthcare centers. So, over the past century and a half, the way that people die has really significantly changed. So, before the 1900s, people lived oftentimes in intergenerational family units. There weren't doctors that were, available in a hospital-type setting. Like the doctor might come to your home to attend a complicated delivery or to sit at the bedside of a dying patient. But it was mostly done by family members. So it was very common to experience birth and death in the home, and that was part of the mystery of life. And if the doctor even came, or if there was a hospital available and a team to attend, there often wasn't that much that they could do to intervene in the course of the illness. And then things came about, such as antibiotics, vaccines, and ways of supporting people's breathing and heart function, of bringing them back from the dead. So CPR was developed. And people began living longer because we could support their failing organ systems. We could cure some of their diseases, cure some infections, begin to cure some forms of cancer. But people lived with increased morbidity. So even if you survived an infection of your lungs, maybe your capacity, your respiratory capacity might be significantly decreased. And maybe your kidneys took a hit, and so people began having longer lifespans, but with more and more organ systems that were not working well, and then interacting with each other to not work well. And so now, in the 2000s and beyond, we have this emphasis on youth and health, and so everybody wants to be young and healthy no matter how old we are. Death is oftentimes seen as a medical failure or a failure of our hospital system to prevent a death. And death occurs more often in medical facilities than a home or a nursing home or where someone has been living. Oftentimes, in pediatrics at least, from withdrawal of certain kinds of support. So compassionate extubation, stopping a VAD or ECMO or something like that. I'm just going to remind myself to say right now, when I talk with healthcare professionals, I use terms like withdrawing support and withdrawing care. When I talk with families, I do not phrase it that way, because to me, we provide some of the most exceptional care in those moments when we've turned away from life prolonging and towards providing comfort care at the end of life. And I don't want it to be confused by saying withdrawing care. Some families, they really fear that that means people aren't going to check in on them anymore and they're going to be left alone in their room, whereas, nurses, RTs are in there attending to their comfort during that time. So I try to use other words like focusing on comfort instead of on prolonging life, or turning away from interventions that are no longer helping us reach our intended goals. Because usually we're doing the intervention to try and help us get to a better place of healing. And once someone is in a situation where we don't feel like they're going to get to that place of healing and back to a different baseline, then that's a time when we should have these conversations. So these are just some definitions of what I mean when I say serious illness. So serious illness is the term that palliative care providers prefer for patients who would be appropriate for a consultation for our team. And it's oftentimes a balance between the serious illness, what illness, where is it along its trajectory, and the family needs. How is the family dealing with it? There are some families who they kind of know exactly what they want and it fits with what the medical team wants and things are going very smoothly and there might not be that much that our team can add, and it's okay if they don't consult us. There might be other situations where the patient is exactly the same but the family and the team aren't communicating clearly or have different goals, where I think we could be really helpful, or the family doesn't have the resources of extended family and community that's supporting them through the process. So, but these are the sorts of things. So life-limiting conditions where there's no reasonable hope for cure and will likely ultimately be fatal. So muscular dystrophies are one of the examples of that. And we're consistently pushing back further how long patients can live with some of these things, especially with advent of different types of respiratory support and airway clearance mechanisms that keep their lungs healthier. But eventually most of them, well, all of us in general, reach an end, and theirs is typically, for this category, sooner than what we would consider a normal lifespan. And then life-threatening conditions where curative treatment may be feasible but may fail. So cancer would be an easy example of that. Some forms of infection that we have treatment for, but it's not as likely to be successful. And then chronic complex conditions are described as a medical condition expected to last at least 12 months unless death intervenes, and or any condition that involves several organ systems, or, that's supposed to say or, one organ system enough to require specialized pediatric care, often at a tertiary medical center. So this might be congenital heart disease, where it's really one affected organ, but that organ affects how everything else works and how we need to work together to support a child. So that's what we would call a chronic complex condition. And these are the types of patients that our team often follows. And one of the big differences, I think, between pediatric palliative care and adult palliative care is the adult team is often working with people very close to the end of their life. Whereas our team is often working with families sometimes from the start of life or even before the start of life, because when these conditions are known in advance, then we have an opportunity to get on board as part of best care right from the beginning. Or if there's a traumatic injury or something that happens, then we have the ability to get on board sort of early on in the course of when it happens. With certain cancers, we're getting earlier consults as well to be part of the ongoing decision-making process. And our team very much feels that we want to help patients and families establish their goals and change them over time. So if their goal is for a bone marrow transplant, they can still have palliative care follow alongside, because they're going to have symptoms and they're going to potentially have a moment where they have to decide, is this still the right route to be on, or do we want to change paths? So we oftentimes follow patients for months or even years. And this is sort of another description of that. So we support quality of life, attempt to relieve suffering for children and their families, because when a child has an illness, and probably adults too, so when I say child and make it sound like we're so special, when an adult has an illness, the family has the illness too, right? Everybody's involved in trying to support it, but even more so for a child where their parents are often the ones giving medications and having to make decisions. So regardless of the stage of illness, There are times where people have consulted us and we've said, oh, you know, that's a little too early. You don't even know the diagnosis yet. The family, you know, really isn't going to know how to make the decisions without that information yet, and it's coming soon. So there are lots of kids we follow who never get a specific diagnosis, but there are some where we know that we're in the testing process and we should give it a little more time. And there are other times people consult us and we say, oh, you know, that's not necessarily a life-limiting condition at this stage in their illness. So an example might be lupus. You know, some people can live well with lupus for many years. So bringing palliative care on board early might not be seen as being as helpful as in something where we know that they're going to have potentially a shortened lifespan. And our goal is really to help the patient and family make each day the best day it can possibly be, whether they're in the hospital or at home.